Alright guys, so today I'm going to be discussing chest tube drainage systems. So before we jump into all the elements that you need to include in your knowledge base for the chest tube drainage system, let's discuss some basic features of the lungs, okay? So the thoracic cavity and the pleura that we discussed in the previous video, it's got negative pressure. What that means is that every time the black line right here, which represents the actual lung tissue, when we take deep breaths, when we breathe in, when we inspire air, the lung tissue expands outward, which we discussed brings in oxygen, and then when we breathe out, it eliminates carbon dioxide, right? So we need that negative pressure within the thoracic cavity, within the pleural sac, to allow the expansion of the lung and the recoiling of the lung so it can push the air back out, the metabolic waste of CO2 back inside. Back outside into the atmospheric air. Now, we can come across some specific problems. We have something called a pneumothorax. And a pneumothorax happens when there's a puncture to the thoracic cavity, you get stabbed, you get shot, something like that, right? And at that point, since the lung tissue, since the thoracic cavity, the pleura is negatively pressurized, the atmospheric air is going to be sucked inside. And when that atmospheric air is sucked inside, something happens to the lung tissue. The lung tissue collapses into itself. And that's what we call a pneumothorax. So the black line right here representing the actual lung tissue, it collapses within itself, and now the lung can no longer expand, making gas exchange less efficient. And so when you auscultate your breath sounds on the affected side, you're going to have absent breath sounds, or at the very least diminished breath sounds, depending on the extent of the pneumothorax. So keep in mind, a pneumothorax is an injury where we have an opening in the chest wall that releases the negative pressure, and it starts bringing air from the atmosphere inside the thoracic cavity, the pleural space, which pushes the lung tissue and prevents it from expanding, and that's what we call a pneumothorax. You can also develop something called atelectasis. And so atelectasis is spontaneous lung collapse that does not occur necessarily because of a penetrating wound, but it happens because of some degree of obstruction, maybe a mucus plug, in the small airways, in the bronchioles, which changes the pressure, and then the lung collapses within itself as well. So when it comes to pneumothorax and atelectasis, the etiological factors, what causes the lung collapse, is slightly different, but the concept's still the same. In both of these situations, the lung is collapsing, the patient won't be able to breathe adequately, right? Keep in mind that when you have either of these two, you're going to have absent breath sounds, you're going to have the patient manifesting respiratory distress, shortness of breath, the utilization of the accessory muscles, nasal flaring, all of those basic elements that are going to be included when somebody has respiratory issues, right? It's important to keep in mind that with the pneumothorax, because the atmospheric air is being sucked inside the chest cavity, your immediate intervention is going to be to plug that hole. How do we do that? You need a sterile, occlusive dressing. Okay? You need a sterile occlusive dressing. Sterile because you don't want to present any pathogens into the opening, which is going to increase the likelihood of the patient developing an infection. It's got to be occlusive because you want it to be impermeable to the atmospheric air so it won't further collapse the lung, create more pressure that's going to further limit the expansion of the lung. So that's what you would want to do. And when you do place that, let's say this is the opening of the chest, the hole of the pneumothorax, you put the sterile occlusive dressing like such, and you tape 3 sides. The reason why you want to tape 3 sides is because if the air is going to passively come out, well, that fourth piece that's not taped together will open up and the air may actually come out. But if for whatever reason the sucking chest wound, it's sucking the air in, well, the sterile occlusive dressing will flap and close on that opening and will prevent further air from entering the area and exacerbating the pneumothorax. So just keep in mind, folks, that anytime that there is an opening, whether the patient already had a tube inside, which we'll be discussing that in a little bit, and it came out, you put a sterile occlusive dressing to prevent any of the atmospheric air from entering the thoracic cavity and furthermore exacerbating the pneumothorax. Keep in mind that as the pneumothorax continues to get worse, the air that's occupying that space is going to put more pressure, and the pressure is going to be confined to the affected side, but eventually it starts pushing all the other structures to the contralateral side, to the unaffected side, meaning that the structures are going to be deviating that way, and you may even see tracheal deviation. The trachea will start moving towards the opposite side, to the unaffected side, because the gases are building up in this side and it's pushing that way, and that's going to compromise the other lung, because the lung then is going to have more pressure being placed on this side, limiting its expansion, and that's how your patient with a pneumothorax may actually expire, or they may die like this. So just keep all these basic elements in mind. Now, to prevent these things, not to prevent them, but to fix them, well, we need to find a means of entering the thoracic cavity and removing those gases. Now, you can develop a pneumothorax, okay, which is what we just discussed. A puncture in the lung, gases fill up the pleural space, it limits the expansion of the lung collapse. But you can also develop a hemothorax. And that develops when a blood vessel starts leaking because of an injury, and instead of this space right here being filled with air, it's going to be filled with blood, hence the hemothorax. And the signs and symptoms are going to be almost identical to the pneumothorax, as in it's going to fill in the space, limit the lung expansion, and it's going to put more pressure, pushing all the structures to the contralateral side. So, with our foundation being set, we understand that the patient may have either air, gases, or may have some type of fluid, whether it be blood or whether it be pus, in case it's secondary to an infection. The goal is to remove those fluids, to remove that air, so we can evacuate it, so we can then allow the lung to expand. So that brings us to our chest tube drainage system. This is known as a closed chest tube drainage system. What we mean by closed chest tube drainage system is that the space where the air moves through, meaning the chest tube itself, folks, is attached with a hose, with a tube, to the wall suction, okay? And it's usually going to be set at intermittent suction. Okay? Intermittent suction means that it sucks out and then it relaxes. It sucks out and then it relaxes. And so what ends up happening is it's pulling air this way. So keep in mind, the collection of air fluids that we have in here start making their way through the opening of the chest tube that's inserted inside the lung tissue, correct? Now, a doctor does this insertion of the tube by using a scalpel, creating an incision between the intercostal spaces and inserting the tube. What you have to understand is that we're trying to alleviate the gases of the fluids. Now, the suction container right here produces a force that will bring in any air or fluid, as you can see outlined in this orange color, and it'll start filling up the first compartment. The first compartment is known as the collection chamber. Okay, and the collection chamber is not going to be emptied at the end of the shift. Okay, it is part of the output. What you have to know as a nurse is when you're measuring the output of this collection chamber is that every shift you're going to see how many mLs are being collected for that shift. You're going to draw a little line, you're going to push your little initials, and you're going to tally up the total output for the shift, and you're going to add it to the output. So make sure you guys keep that in mind. Now, the fluids build up in this space. Once this little chamber gets filled up, it spills out into this little location. As you can see, little drops are going in there as well. However, the gases that we have inside that pleural space continue to move this way, okay? And once they leave the collection chamber, they start making their way into another chamber that's very important for you guys to be able to recognize. It's the middle chamber, and this is known as a water sealed chamber. So I'm going to abbreviate water as H2O, water seal chamber. Now, your water seal chamber is perhaps the most important section of the closed chest tube drainage system, because it's going to have a small amount of fluids, about 2 cms of water pressure in here. And that air that's passing through is going to go this way and this way, and it's going to make its way into the water section of the water seal chamber. There's a small amount of fluid inside, usually 2 cms of pressure. Now that air that's passing through will be going this way. And just like any cup with water and a straws in it, as you push air inside, which is what's happening here, there will be some slight bubbling. And then the air will come out this way. Okay, so you have some bubbles in here, very minute amount of bubbles, and then the gases continue to move their way out this way. Okay, then they go this way, and they make their way outside the actual suction tube that's attached to the last chamber. And this last chamber is known as the suction canister or the suction chamber. Okay, so the suction chamber is going to have about 20 cms of water pressure inside, and this is what's going to be known as the control, which you don't have to really know about just yet, but just understand that the amount of fluid in here dictates the pressure that's going to be sucking, the force that's going to be applied to the removal of that fluid, of those gases that are inside the lung tissue, or the pleural space, excuse me. Now, what you will see in here is not excessive bubbling, but you're going to see more bubbling. There's more fluid. It's attached or connected to the direct location as to where the air is being sucked out towards the suction device on the wall of the hospital. And there's going to be another little opening, because remember when I said in the beginning of this that this is a closed chest tube drainage system? Because from the patient to the tubing to the chest tube drainage system, all the way to the suction at the wall, it's all connected, meaning that it's all enclosed. It starts at the patient, and it ends at the suction device on the wall. So keep in mind that that's what we call a closed chest tube drainage system. It's enclosed. We have a little opening here because since the air is being sucked in this way and it's going out that way, if this was closed off, eventually the chamber itself would collapse within itself. It would break. However, we have this little opening so it can bring some atmospheric air inside, traveling this way, out this way, and that's why you see these little air bubbles that are more populated than you would see in the water seal chamber. And this opening alleviates the excessive pressure that's going to be placed on that canister device, so it won't break into itself. It won't be crushed. And this is the water seal chamber. A couple of things you guys have to remember, that as the patient is laying in bed and they have this chest tube drainage system attached to them, the patient's still trying to breathe. The whole goal is to expand the lungs. So keep in mind that the goal is lung expansion. That is the goal. So we're going to be teaching our patient to cough and deep breathe, to utilize pursed lip breathing, so we can hopefully bring that lung out this way. And once it's fully expanded, then we can remove the tube from the patient. However, before we do that, we have to understand some basic fundamentals. As the patient's breathing, even though that lung is not fully expanding, it is moving a little bit. It's probably moving from this line that you see here, maybe to out there. And when the patient breathes out, it goes right back to that little location there. So it's probably moving a few cms. However, as that lung tissue moves a little bit, since it's closed chest tube drainage system, the pressure does move throughout the entire chamber. And that's why at the water seal chamber, as the patient breathes in and out, you're going to see something happen with that fluid. And that thing that happens is called tidling. Okay, like the tides of the ocean, right? They go up and down. That's what happens at the water seal chamber. As the patient breathes in and out, it tidles, it moves up and down with a little bit of bubbling. This is important because we have to set our foundation. What's supposed to happen at the water seal chamber? So you understand what to question, what to report when the foundation, when what's supposed to be happening is not happening anymore. Okay? So that's what we're supposed to see. Every time the patient breathes in and out, there should be some slight tidling, which coincides with the patient's respiratory effort. Now let's discuss what we report. The elements that are abnormal are potential plugs or kinks within that tube. If that tube becomes obstructed for whatever reason, these tubes are a lot longer than that, and they connect to each other, and then we have to apply tape to create that seal so none of the atmospheric air gets sucked inside the tubes. Okay, we don't want any leaks. At the same time, we don't want any fluid collecting inside here and causing an obstruction. We don't want that. Now, we said that there should be some tidling in the water seal chamber. If at any point the tube becomes kinked, or if there is an obstruction, can the air move from the patient? Will the pressure be felt right here in the water seal chamber if there's an obstruction? No. So when you have no movement in the water seal chamber, you must report it to the doctor because it may indicate some type of obstruction. Maybe it's a mucus plug, maybe there's a kink in the tube, maybe the patient's lung has fully expanded and it's healed, or maybe the patient's dead and they stopped breathing. Nonetheless, you want to make sure that you report it, that you assess the patient when you have that abnormality. What we're supposed to see is tidling, slight few bubbles. But when you don't see any movement, that indicates a potential obstruction of the tubing. Now, if at some point this tubing right here leaks, meaning it's cut open, let's say. Now, because this is negatively pressurized because of the suction device at the wall, it's sucking air this way. Well, now that it's no longer closed, that atmospheric air is going to start making its way in there. And it's going to be sucking in a lot of air, and that's going to cause turbulence in the water seal chamber. So whenever you see excessive bubbling inside the water seal chamber and excessive movement of that tidling that we discussed, you must report it because it may indicate some type of a leak. At the bedside, we discussed the sterile occlusive dressing. You must have a sterile occlusive dressing at the bedside in preparation for this potential that the tubing may slip out of the patient's chest. And at that point, we cover it, we tape 3 sides, and we discuss the rest. At the same time, you want to have clamps at the bedside because if there is a leak, you want to clamp the tube proximal to the patient so none of that atmospheric air gets sucked inside the patient's lung, which is going to further collapse the lung, and the patient will have to start all over again in regards to the time spent on the chest tube drainage system. At the same time, folks, you want to make sure that you identify the 3 chambers that the chest tube drainage system has. We have the collection chamber, we have the water seal chamber, which is supposed to be tidling with a few bubbles, and then we have the suction chamber that's supposed to be bubbling with a lot more bubbles. There should be a lot more water, and these are the elements that are supposed to be occurring with the actual patient chest tube drainage system. I hope that made sense, guys.